Yes. Thank you, Adriana, for your kind introduction. I'm really honored to be here. This is the second time. And I wanted to mention I really don't have any conflict of interest. However, I'm going to present you actually a lot of research that we have done about over 10 years. And really, this was completed almost 15 years ago that we published in some, mostly in abstract form, but also some papers. But I thought that it's probably more relevant than ever to what we have, how this syncs with the results of recent clinical trials, particularly of GLP agonist in cardiovascular disease. And if there's a conflict that I'm biased about, I'm going to try to convince you at the end that anything we can do to cut the sugars and refine carbs, cut the seed oils, eat marine fish 3 times a week, exercise 30 minutes daily, not 3 times a week, and most important, manage our emotional stress however we can do. And I think that can make a more impact than actually any drug we ever developing for cardiovascular disease. Before I go into that, at least for the house staff, I want to show you 30 years worth of experience as a practicing physician that I thought there will be some tips that may help you. How can you learn to be a better doctor? You have to understand you can't outrun burnout with productivity. Medicine rewards stamina, but working over 8 hours a week and constant pressure comes at a cost. And I learned really that the hard way that rest boundaries and life outside of medicines are actually not indulgences. They're actually necessary for long-term survival in this field. The system is broken. The system is designed for financial transaction. This is the ugly truth. And often we're going to feel pressure to either we can decide to break with it, or we can try to stay out of it and protect it, our values in our patients. You'll face pressure to treat charts, hit our views, please insurers and hospitals. But your real job is going to be to advocate for our patients, for our own integrity. It can happen. We just have to focus on that. In terms of learning, although it looks like you're learning the most during your residency, you're going to learn the most the first 5 years you are actually out in practice, when you have to make decisions for your patients. You're going to have to learn that our guidelines, unfortunately, only help us in probably about 10% of the patients. We're going to have to come up with something else. So know what's worth learning, and know that you're going to have to look yourself for valuable information. And I learned the most valuable lessons will not come from journals and guidelines. Not they are not required, but they will come from patients, from mistakes, and from study the totality of evidence-based medicine, not the ones that to answer clinical questions. If your patient is getting better, you're doing good. If the patient is not getting better, we need to look back. Something else is missing. And we have plenty of evidence. We just have to look outside from what we're used to. And who you are matters more than what you know. What makes a good doctor is not what you know. What makes a good doctor is who you are. You continue to develop yourself, and have humility, have presence with your patients, being the kind of doctor your patient wants to talk to when they're scared, in pain, or overwhelmed. That's going to make the biggest difference. After that, now we're going to go and discuss some clinical trials about really what's the evidence that supplementation with the good fats, the omega-3 fatty acids, makes a difference, at least in cardiovascular prevention. I'm going to try to convince you about some mechanisms that this may work, and a lot of it will be some prior research that we have done in our lab. And we're going to talk about how actually to do it, how to supplement, whether it's from fish oil supplements or from medications. So about a year and a half ago, when I came first time, I submitted to you the hypothesis that the best way to really approach what causes cardiovascular disease is going to be to look at more of a global integrated perspective of human health and disease. And really, I tried to submit that mitochondria are a biological clock that determines our fate. Dr. Nick Lane, who is an evolutionary biologist at the University of College in London, proposed, based on the fact that mitochondria have been integrated in our cells about 2.2 billion years ago. And it comes with a certain limitation that our mitochondria is a big Tesla battery. It's supposed to drive it for 500,000 miles, has a limited maximum amount of recharges, and it's supposed to last us for 120 years. And our lifespan depends on how well that can last. And risk factors really overall, they reduce and limit the number of those charges. But if you look at all chronic illnesses, what they really have in common is mitochondrial dysfunction, one way or another, which is and what's behind that mitochondrial dysfunction is oxidative stress, inflammation, insulin resistance. Now, those are words that you've heard before from the day one you actually started to go into medical schools. I'm going to try to show you actually there's the practical implication of that and how you can actually navigate through this. And I'm going to submit today what I learned is that you cannot just look only on one type of evidence-based medicine, which is for us clinical trials, but also if you actually look at totality of evidence-based medicine from physics, biochemistry, cellular biology, physiology, that can give us a bigger picture of where to go from there. And I'm going to present some of that. I did that homework for you. So I've studied this for over 20 years. And here's first what we learned when we actually read prospective randomized clinical trials. It's very good to tell us the true mechanism of disease progression in humans. And that's important. So, for example, if I have acute ST elevation myocardial infarction, what we call acute coronary disease, okay, after we use either thrombolytics and percutaneous stent placement, we drop that mortality from 13%, how it was before in the 70s, to about 1.8%. What I like to do, is actually to look at the residual risk, meaning how many people have benefit from this from 100? Well, 86%. What it means, if I have impacted at least half of those patients, that is the true main mechanism of that particular disease, okay? In the same time, there are 14% have not improved. Sure, I can concentrate why the others haven't, but I know that's the main mechanism for that disease. Now, so I know that mechanism. What about for chronic illness? I'll give you an example. Chronic systolic heart failure progression. What happens if we put the patients on those 4 pillars, what we call of GDMT? Well, the mortality drops from 35% to 10% in 5 years, which means 71% benefit from. And the way you get that 71%, you divide 10 by 35%, and then you multiply by 100. So, which means it's again over 50%. That means those 4 drugs, those 4 mechanisms, which are all related to stress hormones and insulin resistance, if I interfere with that, I intercept progression of systolic heart failure. Now I'm going to look at cardiovascular prevention side, chronic coronary disease. So what have we learned from that? Well, the most potent studies we have when we try to target LDL cholesterol to 30 to 50 milligrams per deciliter, high-intensity statins with PCSK9 inhibitors, the Odyssey trial, the Fourier trial. We look at what's the impact of those. The incidence of major adverse cardiac event dropped from 11% when the LDL was more than 70 to 9.8%. So notice the 9.8 out of 11 is 87. That means it doesn't matter how low I'm going to burn that LDL cholesterol using these methods. I'm not impacting the main mechanism of coronary artery disease progression. Now, cardiologists may not like to hear that, but it's the truth. That doesn't mean they don't work. And we're not going to try to offer them medicines, and we should do it according to guidelines. We're not impacting the main mechanism. So this is the part that I'm interested in. What is there that causes progression of coronary disease that's independent of lowering the LDL cholesterol? LDL cholesterol is not everything. So what we have learned, according to Dr. Doug Wallace, who's probably the most, one of the most important mitochondrial researchers, the mitochondrial dysfunction is the underlying cause, not just of cardiomyopathy and cardiovascular disease, but all the chronic disease conditions and aging, including Alzheimer's and cancers. If we look particularly in cardiovascular disease, if you follow these patients long enough, turns out there's a very tight connection between insulin resistance, prediabetes, diabetes. Prevalence in anybody who has cardiovascular disease, it's 82%. With this, I'm talking about heart failure with the reduced ejection fraction, heart failure with preserve ejection fraction, 82%. So it's very tight correlation. And this is, and there is to no surprise, according to Dr. Doug Wallace, why? Because if I were to look at the mitochondria at this, how energy is extracted at the single electron transport chain system is actually from the whole foods that we're supposed to eat, is actually 1 electron at a time. Why is that important? Because the energy from that 1 electron at a time, which allows us to extract a lot maximum energy from very limited substrate, creates this proton gradient, which then drives the ATP synthesis. But there is a catch. That ATP has to be consumed. If I'm not exercising and I'm going to back up this electron transport chain, or if I'm feeding too much substrate, particularly with highly processed foods, like anything contains fructose, polyunsaturated fatty acids, alcohol, then that electron transport chain gets overwhelmed. And now we have an electron that's going to go straight to the oxygen, cause superoxide and hydrogen peroxide. And that's a stimulus for this mitochondria to tell the cell, wait a minute, we got too much. We need to store or to grow. So then Krebs cycle, if you remember, doesn't just make ATP. It makes substrates like acetyl-CoA. So then the Krebs cycle backs up. All that acetyl-CoA goes backwards and starts to be stored in carbs, in fatty acids. And then it signals the pancreas, we need storage. What is the most potent hormone we have to store? Insulin. That's why the insulin is released in somebody who has abundance, and that mitochondria is overwhelmed. And then we move overall the whole body level into a storage mode and a growth mode, which that does not helps if you're young, if you're in fetal life, you're a kid, we are pregnant, that's healthy, that's why we have this, but not if you're an adult and grown up. So that's in a nutshell the hypothesis that we're going to work with. I'm going to show you some of our prior research data looking at that. Back then, when I was your age, a young scientist in my mentor's lab, Dr. Kathy Grilling, we tried to look at, we harvested 20 hearts from patients who underwent heart transplant, and we look at their over 50 coronary artery segments. And we're looking into what's the oxidative stress, if it's really true, this hypothesis. We measure it within 30 minutes. Here is in red, we did a special staining showing you that this is a plaque that occludes about 50% of the artery. And here, heavily in red, it's actually a lot of superoxide and free radicals that are produced by the macrophages, mostly inflammatory cells that are there. If you were to look into other arteries, they have, there are earlier stages of atherosclerosis, and you really look where it happens. It's in this shoulder of the stain. It colocalizes with these NADPH oxidases. They are both either from phagocytic and non-phagocytic cells. But what's the fascinating part is if you look what kind of cells are those, they're here in this atherosclerotic plaque. A lot of them are smooth muscle cells, but there's different smooth muscles than the ones that are in the differentiated media. These are actually, we call this synthetic phenotype, muscle. So what you see here, those synthetic phenotype muscle cells that migrated, they no longer contract. What they do, they are pro-inflammatory, their growth, they divide, and they are insulin resistance. In order to do that, Dr. Rosa Clampus, he isolated them from coronary arteries, put them in the dish, and then you see immediately within the first passage, they're all express differentiation markers. But if we keep making them divide, and that requires actually high insulin and high glucose, is actually equivalent to 400 milligrams per deciliter, then they become this synthetic phenotype, they lose those markers. And what happens is they start switching from contractile phenotype and normal insulin, normal glucose, using the Krebs cycle to make ATP into actually a synthetic phenotype that is actually the Krebs cycle and mitochondria are no longer used to make ATP, but they are used to create substrate for growth, proliferation. And the main source of ATP for those cells is glycolysis, not in the Krebs cycle, outside the mitochondria, which is used for proliferation in fetal life. Basically, those cells revert where you used to do that. And you require, in order to do that, we require oxidative stress. We require stress, the same stress hormones that cause heart failure, and TNF-alpha and high insulin. What I'm trying to say is that high insulin, persistent high insulin, is not damaging just through high glucose that causes hemoglobin A1C and glycation. It damages because it becomes a growth factor that's highly inactivated chronically. So that's how insulin is bad. All right. And we do these switches and we can change those. And it turns out that every cell in our body, once we have metabolic syndrome under high insulin, changes their phenotype. I just gave you an example for smooth muscle cells, but we have evidence for cardiac myocytes. They change what we call into a fetal cardiac myocyte that is no longer able to do good contraction, but it does adapt us. We have macrophages. They move from anti-inflammatory macrophages M1 to pro-inflammatory macrophage, type 2. The Treg cells, our T cells, are supposed to defend only us against the invaders. This time they start to be autoimmune and pro-inflammatory. And actually now there's evidence that these T17 cells, they become actually a mediator for hypertension and every single coronary disease we can imagine. Fibroblasts become myofibroblasts. Hepatic cells become now storage fatty liver cells. So this changes under chronic insulin production, hyperinsulinemia, which we never tested in the lab until we get diabetes, are changing our body long time before we actually get a cardiovascular event. And that's important, all right? From an anti-inflammatory phenotype to a pro-inflammatory phenotype. Often these conditions, when we start having coronary chest pain, if you actually look and you talk to the patient, you'll see it coexists with autoimmune thyroiditis, sometimes, colitis. From our mitochondria making ATP into a mitochondria, they are designed for substrate handling and growth and inflammation. So this is an important concept. Mitochondria signal back to the nucleus and say, we need to become a divider cell. We need to become a growing and storage cell. It's called epigenetic signaling. So everything changes. So this is the hypothesis, and the hypothesis we have plenty of evidence for, is that this is if you look here, normal person who just had a nice, breakfast or lunch, you have insulin spike and it goes back between the meals back to normal. All right. Somebody who's got hyperinsulinemia, metabolic syndrome, the insulin stays still up even after 12 hours fasting. It didn't get back to normal. And this is when it functions as a growth hormone. And why is it that insulin has to stay up in those who are unable to handle these substrates? It's very simple. The reason why insulin is resist is just like hypoglycemia can kill us very fast. Hyperglycemia, it's extremely toxic to all our cells in the body. That's why insulin is resisted. You got to get the glucose immediately out of the system and put it into storage. All right. And I tell my patients, when we put something sweet in our mouth, there's only one organ that is happy about it. That's your tongue. After that gets into the system, every single cell in the body hates it. Because glucose, if you remember, it's an osmotic active particle. Once it gets in the cells, increases, attracts water, cells swell up, our nerves, our eyes are the most sensitive. So it needs to be stored and trapped before it stays for too long in the cell. So insulin has one of those jobs, and the other job is glucose. They just persist in circulation, just starts to deposit on the proteins and gets oxidized. That's how it's called advanced glycation end products. That's called hemoglobin A1C. So to me, hemoglobin A1C, contrary to our diabetes guidelines are, that it's only abnormal if it's more than 5.7. It's not true. Anything that starts, you took one today, it was 5, and a year from now, it's 5.4. You're getting oxidized. You're getting old. It's telling you what's the oxidative status overall of your body. And that's part of it. And yes, this doesn't mean you're going to drop dead when you got to 5.4, but it tells you the direction that we need to start working on that. And of course, our clinical trials, they all emphasize what we call secondary prevention. We only start to worry about diabetes when hemoglobin A1C is over 6.4. Okay, but that's wrong, because for 15 years prior to that, our insulin level is high. It's already working as a growth factor. It's already oxidizing our cells, changing our phenotypes. And this is where we're missing. And I'm trying to get your attention to that part that we've been missing to prevent cardiovascular disease. That's why we haven't impacted, so much. Okay, so let's see if we can do that in a different way. But for now, take home message. Pre-diabetes, insulin resistance, diabetes is bad two ways. One, the way we know when glucose goes up, that we can detect it by one simple fasting glucose. Two, that fasting glucose being high, constant over 105, suggests insulin is high. Insulin is high, you're growing in the wrong places. That's the setup for cancer. That's the setup for cardiovascular disease. That's the setup for Alzheimer's, chronic illnesses, but also accelerated aging. And that's the take-home message. I'm going to show you how you can detect that without that. But here's what's the evidence that hyperinsulinemia is a problem for cardiovascular disease. You know, this is a study from New England Journal. We've known this for a long time. If you look at how high LDL or high triglycerides can predict cardiovascular outcome, notice that only when insulin, if insulin is less than 12, minimal impact on the LDL. Here LDL will be the surrogate, will be ApoB. No impact, doesn't matter how high is your LDL or your triglycerides if your insulin is less than 12, fasting insulin. Once your insulin starts to go up, everything is enhanced 5 to 10-fold. So it's the insulin that is the sensitizer marker for that. And this was known actually a long time ago, was with, you know, the one who taught us in 1988, Dr. Gerald Raven, a very famous endocrinologist. Those who are endocrinologists know him at Stanford, who he really studied insulin resistance, and he showed that if you take, you know, 100 patients and you follow them for 10 years, if you have no insulin resistance, if you have intermediate, and if you have high insulin resistance, the single most important predictor of cardiovascular outcome after 10 years was if they had developed insulin resistance. And he is the one who actually came up with the concept of metabolic syndrome. It used to be called Raven syndrome initially, and says, look, it's not just about the LDL, it's about how your insulin resistance makes toxic those other cardiovascular risk factors. Now we have more data from recent, for example, cardiovascular outcome. It's called Accelerate trial. When we try to raise the HDL with a CETP inhibitor, it turns out that 67% of those who were not helped, they had insulin resistance. If your fasting insulin level is over 26, it doesn't matter what cardiovascular drugs you use, you are not going to prevent coronary disease. So this is from recent. And the single most important predictor is actually triglycerides to HDL ratio more than 2.5. And I know it's not in our guidelines. We don't look into that. Why? Because that is not the total LDL that matters. It's the oxidized part of the LDL that matters. And that's predicted by triglycerides to HDL ratio, or if you will, diabetes at the molecular level in the liver, which is fatty liver. So I'm going to propose to you that improving insulin resistance is a key strategy for managing and slowing the progression of coronary disease. And really, coronary disease progression cannot be prevented unless we improve insulin resistance. That comes on top of other risk factors you might have. That does not mean people have genetic problem with the LDL or some other etiology, which has less than 10%, don't matter. All it means this adds on top of everything else. Whether you have bad genes or you don't have bad genes, then we need to do it. All right? So, you know, really, what I mean by ultra-processed food is any combination of fructose from sugar, linoleic acid from vegetable oils, heated up, combined in some kind of prepackaged that causes this independent of calories, makes us eat more, causes fatty liver, diabetes, insulin resistance, and ultimately mitochondrial dysfunction. And eventually, if I were to look at end organ damage like coronary disease, hypertension, heart failure, mortality, if I want to design a drug or design a lifestyle change that will have a meaningful impact, I have to impact all these three of them. You know, cut the ultra-processed food, impact the fatty liver, and impact the insulin resistance. So you can say, I can talk all I want, show me some data, show me some prospective randomized clinical trials. Well, we have them. Here it is. Select trial. Patients with prior coronary disease, morbid obesity, BMI over 27. We put them on semaglutide or equivalent tirzepatide. We drop their weight by 10%. We improve coronary disease by 20%. And say, okay, well, it's obesity. Not so much, because how does it work? It blocks your brain from eating food, any food, ultra-processed food including. So I'm impacting one element, I'm reducing that. The second one, it's actually the single most important and most really profound change in these patients. It prevents type 2 diabetes after 5 years by 75%. Notice coronary disease only by 20%. But the most important medicine we ever came up with is this medicine by dropping 10% of the body weight. 75% prevention of type 2 diabetes, 60% reversal of pre-diabetes. These are patients who did not have diabetes to go in the trial. They excluded them. These are patients who 60% had pre-diabetes, and 2/3 were reversed, and then 75% did not progress to type 2 diabetes. So to me, if I were to see what's the mechanism how this works, they really just dropping the weight, fix their diabetes and pre-diabetes and their metabolic syndrome. That's how it worked. All right. And then, of course, we have evidence that also improves fatty liver insulin resistance. What about the other end, heart failure end? Well, we have clinical trials for heart failure with preserved ejection fraction. There are actually 3 of them, the SUMMIT trials and the STEP trials. Again, morbidly obese patients, plus minus type 2 diabetes. They drop 10% body weight, improve 35% cardiovascular death or worsening heart failure event. Big difference, yes.
Mechanism. So why metformin would be more effective than this because metformin will work in green pathway.
So I think that's a study. It would be nice to compare, but metformin, as you know, is approved for to try to, once you have obesity, to try to reverse. So in early stages of pre-diabetes metabolic syndrome, it helps, particularly with obesity. This is a bit more advanced patients, right? We have already cardiovascular disease. It would be nice to see what happens if you add metformin or if you compare with it. I think because metformin doesn't drop that 10% drop in body weight is a requirement to reverse insulin resistance. Because when you lose at least 10%, we have data showing that you start to fix fatty liver. Okay, metformin is not that potent for that. So I think that's. But the bottom line is, again, clinical trials used to show your mechanism. What really was missing is not the obesity per se. Okay, and many of them, by the way, 25% don't lose, but they still reverse a lot of this stuff. Even their weight doesn't change much. And they show the one with pre-diabetes is really the one that benefited the most with a high BMI. Okay, so based on this, I wanted to point out that fat becomes a mechanism of inflammation in the body. Once we exhaust the capacity to enlarge and store, it starts to become an inflammatory organ. And based on this, for example, in October, there was a whole issue actually in Journal of American College of Cardiology, heart failure. Dr. Milton Packer, who's been really our thought leader in the field for over 40 years, he hypothesized that really, at least in heart failure with preserved ejection fraction, it's a metabolic disease. It's not a cardiac issue. That's triggered by inflammatory, by inflamed, adipose tissue. And we need to think outside of the heart in order to be able to fix the metabolic issues before we can actually improve the heart failure. So based on this, I like to propose that we should, from cardiometabolic perspective, not endocrinology, we probably ought to reclassify cardiometabolic syndrome as a stage 1. We have some form of insulin resistance. Stage 2, after 10 years, we have actually the current pre-diabetes. Why? Because we already start to have cardiovascular outcomes and that. But also now I have drugs that I can show that if I interfere at this stage, I can improve and prevent stage 3. And that's how we do in Heart Failure Society, our ABCD staging of chronic systolic heart failure progression. And that's how we do it in chronic kidney disease. We have stage 1, 2, 3, 4, 5, because we know if we use elements, we can interrupt the process. Go ahead. Sorry, you had a question.
I have a question about the GPI medication on patients who have just pre-diabetes but they're not obese. And I assume that pre-diabetes could reverse by this medication. The question is, how long should they be on it when they are already reversing the pre-diabetes?
Right. So you're saying it, okay, we studied this in obese patients. What about in non-obese patients who have normal BMIs? If you give them GLP-1 agonist and they have pre-diabetes. So those patients are what we call TOFI, thin outside, fat inside. Before they develop fat outside, they develop in their liver, in visceral fat. And that causes the pre-diabetes. I can tell you that we don't really have any data about those patients have not been studied in clinical trials. Okay, should they be on it? Could they get at one point side effects from it? Because you get into a certain state of ketosis. I think those are good questions that probably best answered by actually doing some clinical trials. What happens if somebody has a BMI of 25 starts to lose? What should be the goal? Should we just put them on low dose and just fix the fatty liver or insulin resistance, or shall we have similar goal of making them lose some weight? I don't know. All I know is that when you have fatty liver, all it is 1 extra pound in the liver that can cause the disease that has nothing to do overall your body weight. Okay, so I don't have an answer for you for that, and I would be very cautious.
There are some foreign studies regarding this issue. Are you aware of them?
Sorry, go ahead.
Are there any studies regarding this issue on non-obese person?
Right, no, that's what I said. We don't have studies. However, there's a huge need because from overall all population who has pre-diabetes or metabolic syndrome, about half are obese. The other half are actually non-obese. BMI is 25 or less. As a matter of fact, the highest incidence, 9-fold higher in the last 5 years of type 2 diabetes, it's in this BMI less than 25. It's higher, okay? Yeah, well, what I meant is there are people who, when they store, they first genetically, you have a lot of adipose cells that they can really store outside, and actually they're protected. People who can be obese outside and they store a lot, they're actually more protected before they get fatty liver inside. And there are others like me, I can tell you, if I gain 5 pounds, I already feel sick. My liver enzyme change, everything is different. Thin outside, fat inside. This is where the gene come into play. You're a large storage person or you're a small, inside storage person. And everybody's different. Obviously, in particular, this is relevant for Asian population. Major issue now in Asia with based on the diet. Most of them, they're not obese, but they're extremely high risk of new onset diabetes there. Okay. Bottom line is, these are 2 patients. I want to show you that contrary to what's our expectations and what we've been told, lifestyle changes does work. These are 2 patients of mine. You can say they're anecdotal. They're both end-stage heart failure. One is end-stage heart failure with preserved ejection fraction. 74 years old, cabbage, normal heart function, coronary disease, already with type 2 diabetes with hemoglobin A1C of 9. At goal with our statin therapy, LDL 55, admitted in the hospital with diuresis him 60 pounds. Then I tried to put him on what he called rabbit food diet to rescue. He didn't want to agree. 3 months later, readmitted. We had to give him a stent in his Lima to LAD. Eventually, he decided he's miserable enough. He's going to try to take my offer. All right. Then the other one is a younger woman that I've known for over 20 years. That I noticed is non-ischemic cardiomyopathy, type 2 diabetes, on 100 units of insulin a day since age 18. Declared type 1 diabetic. I saw her EF dropping from 45 over 20 years to 10-15s. She was so obese with a high BMI and with kidney so advanced, CKD stage 4, that we could offer her to send her home a Mirena. And that's palliative, doesn't last long. And then I had the conversation with her. I called her on a Saturday. I said, do you really want to, let's work together. Everything you put in your mouth for the next, week, you take a picture first, you send to me. And then I tell you how to replace. All right. And she had a continuous glucose monitor. And then I replace those meals little by little with things that she can easily do 10-15 minutes. By the way, it's not as expensive as you think. She lives off food stamps. This is not a high income person. It can be done. And within the first patient, after he adhered and we worked together, and basically all I did, I showed them how I eat, nothing else, nothing I haven't done. And again, I'm a busy person. I don't have much time to cook. The first patient dropped over 100 pounds. Okay. Kidney have normalized, still has proteinuria from diabetes. His diabetes has been cured. Hemoglobin A1C is 5.4. BMI is now down to 29 from 42. Triglycerides, which notice were 408. That was on top of Tricor, statins, and everything else. We took him off all that. He's still on statins, but his triglyceride is now 156, and the ratio now is 3.6. Remember, normal is 2.5 or less from a ratio of 13. He has been out of the hospital for the last 3 years. He walks easily 10,000 steps a day. He feels better than he felt in 15 years. No hospitalization since. The other one that I told you, end-stage non-ischemic cardiomyopathy, within 3 days, I had to take her off insulin. Within 3 days, after she's been for 22 years on over 100 units. Okay? Weight dropped gradually by 70 pounds. BMI got better. Hemoglobin 5.7. 6 months later, she's cured from diabetes 2. It's reversed. BMI is down. Now, couldn't tolerate any medicine from my heart failure medicines. Now her ejection fraction has improved. Now she tolerates, she's on GDMT, like it's supposed to be goals of therapy. She walks, she only takes water pill once a week, and she walks 10,000 steps a day, couldn't do 20. The year we discussed this, she had 20 admissions in the hospital and was dying. Hasn't had one since then, 3 years. And she feels better, couldn't walk 20 steps. So it's possible. Of course, this is not evidence-based. This is not large scale, okay? But it can be done by just cleaning up the ultra-processed food. And guess what? These are some ugly statistics. In 24, we had almost 4,500 heart transplants, LVAD 2,500. Total patients living with heart failure reduced ejection fraction, 3.5 million. We helped, and we should continue to do that, 0.2% of this. What about how much we spend on GLP-1 receptor agonists? I'm talking about Mounjaro, I'm talking about Ozempic, 20 billion, the same amount of money, by the way. All right? Okay. There's a catch. The catch is that if you were to look at how many of us are metabolic healthy right now in the whole country, according to Dr. Mozaffarian at Tufts, okay, only 6.8% in this room right now are metabolically healthy, according to the stats, which means you have at least 3 out of 5 of these risk factors for metabolic syndrome that are present. That means 93% of us at whole country as adults are not metabolic healthy if you have at least 3 out of 5. This is the ugly statistics. This is not genes. This was not like this. You know, it was less than 5%. Diabetes type 2 in 1970 were a rarity. It only occurred in people older than 65. This has nothing to do with the genes. Doesn't matter who says what it says. This is exposure. It doesn't matter how you turn it around. And exposure to something that never existed before in humans as we're exposed now. Okay? So that by itself tells you something. But now if I will look coronary disease, and I promise you I'm going to show you the way what happens to the other 80% that we cannot impact with drugs and high statin and PCSK9 inhibitor. Well, the source of it is oxidized LDL. Is 3. There are 3 different LDL particles. One is the standard one that we impact, overall total LDL that we impact with statins and PCSK9 inhibitors. But even if I lower that to 30, I only impact 20%. The other about 8 to 20% are the ones who have a genetic cause, high lipo-A, lipoprotein(a), which soon, hopefully, we're going to have their clinical trials. Now we have drugs, we can wipe that out. We just don't have cardiovascular outcome data, and we're going to have it in a year or 2. So then we can impact another anywhere between 8 to 20%, the lipo-A version. But 2/3 of it, 67%, it's an acquired condition called named prediabetes and diabetes. And that is food-induced diabetes. Okay? It's the triglyceride is lipoprotein. Why? Is the composition of triglycerides, whether they're oxidizable or not, they oxidize the cholesterol, the LDL, and makes it bad. And it's associated with this, with fatty liver, insulin resistance, and obesity. It doesn't have to. And again, to me, if I were to screen from cardiovascular perspective, I like to get my LDL, sure, like we do, but I would like to look at the triglycerides to HDL ratio, and ideally check a fasting history. It's not in the guideline, but it tells me where somebody's going, and that's going to be more complete. So now I keep telling you about this triglycerides to HDL ratio, telling us lots more about cardiovascular disease development than the actual LDL. And the reason is it targets the part of LDL that's oxidized, But then we have clinical trials. What have we learned from it? When we try to either drop triglycerides or increase the HDL. Well, we try first to drop triglycerides with fibrates. No impact. If there's anything, could be worse outcome. We try to increase the HDL with CETP inhibitors. Not on, one trial actually had worse mortality. It didn't work. Then we tried to use high-intensity statin and niacin. No, it didn't work. How about we drop the omega? We drop the triglycerides omega-3s. The strength trial, the largest to date, it showed no difference. So in other words, triglyceride HDL ratio, it's a marker, but it's the composition and how with the body that makes the difference, which means there is no benefit if we don't lower the insulin. And we need to look into what targets the insulin. None of these drugs works that way. Okay, that's the background. So let's see, can we do that in a different way? Well, omega-3 supplementations, which is the topic of today's conversation. What are the clinical trials? I don't want to, you don't need to focus on it. I put this together. You don't need to memorize anything. We have two classes. One is low dose, 1 gram a day for people with cardiovascular risk. This is a Canadian study, no benefit. About 60% patients have diabetes, type 2 diabetes. This is the first one was Italian. This one is Canadian. However, in African Americans, it showed that there was a benefit, but particularly those who were having very little fish in their diet. Okay, so that's important. There was a signal, which was largely ignored. And then in type 2 diabetics, absolutely no difference. So low dose doesn't work. Okay, what about higher dose, 2 grams a day? Yes, the Jellies trial, which is the first Japanese, but only EPA. That means not also the DHA, which is, so EPA is for the cardiovascular system, DHA is for the brain. All right. So that one seemed to have a signal because there were 70,000 Japanese patients with prior coronary disease, higher risk. And the Japanese already eat a lot of fish and they have higher omega-3s in their blood. And that did make a difference, independent of the statin. But the single most important study was extremely positive is actually the REDUCE-IT trial. 4 grams of the same purified icosapent pentaethyl, which is EPA, a day, no DHA, no brain, no EPA, which patients already with 70% coronary disease, high-intensity statin. On top of that, dramatic reduction in major adverse cardiovascular events. And we lack necessary number to treat to look into that, right? So it turns out if you were to look at combined mortality and myocardial infarction, you treat 25 to save 1. Prevent a new MI, you need to treat 3. By the way, just to have an idea, for heart failure progression, we have to put them on all those 4 drugs. Or if we just do beta blockers, you treat 9 to help 1. So this is more impactful than actually chronic systolic heart failure, that we have. And then if you were to look at compared to the statins, you need to treat 83 with statins to save 1 life, as opposed to no DC at 25. So and again, on top of that, okay? So this was amazing. Everybody was very happy. Fine, we're gonna put everybody on this drug. There's a catch. A year later, or a couple of years later, the strength trial came out. This is Cleveland Clinic, okay? The REDUCE-IT trial was mostly Harvard-based by Dr. Bhatt. Cleveland Clinic trial, bigger study, 17,000 patients opposed to 9,000. And similar patients, although less sick, it showed no benefit. But remember, these are both the DHA and EPA. So after that, it was decided that, well, really, we don't know if omega-3 supplementation does it, but if you just do the APAs to make a difference, there was the major criticism of the REDUCE-IT trial was that they use as placebo mineral oil, and mineral oil can actually aggravate the disease in placebo potentially. They decided subsequent studies showed that actually didn't make any difference as opposed to corn oil. But to me, I'm gonna stick with this one, and it shows you some difference there. I am gonna try to propose to you that probably the single most important, the greatest modifier risk factor of coronary disease and accelerated aging will be try to reduce the ultra-processed food in the diet. Of course, experts disagree. What's ultra-processed food? I have a very simple definition. If he wasn't here 150 years ago, it's ultra-processed food. Okay? It's very simple. We cooked for 6 million years the way we cook, and it was just fine. It's when we hand it over to the industry to add other stuff that it does there. If you want for further, I developed this in a whole 3-series lecture that you can find it on a rescue heart failure lecture, and I show exactly what I mean by that, and I review all the literature, including different types of diets. But bottom line is, what's scary is this ultra-processed food means nobody cooks at home. You just buy labeled products. In our teenager, in overall in US population, 62% of our calories are eaten from that, all right, including what you have on your table right now. And then 70% for teenager. This is a scary problem because starting with 2009, we have 2 total new conditions in kids who are younger than 18 that never existed again before in humans, which is fatty liver and type 2 diabetes. Did not exist in kids before 2009, okay? And kids don't drink alcohol to cause that. The kids do have lots of sugar intake. All right, so these are the culprits, actually the chemicals. What are the chemicals that do that? Fructose, and I gave a whole 1-hour lecture about that. Alcohol, I don't have to tell you, but the ones that we focus here is the trans fat, and particularly the vegetable oils, and in particular, oxidized linoleic acid. And the emphasis is oxidized, okay? And we have 2 kinds of fats. We have saturated fat at the biochemical level and unsaturated fat. The unsaturated fat can have this double bond here as a 1 double bond. Those are omega-9s. Or we can have 2 double bonds, omega-6s, linoleic acid. Or we can have 3 or 6. Those are the omega-3s, starting with linoleic acid. And they are essential. For example, the omega-9s are actually, their job is to tell our body to burn the fat, make energy. They help us to to burn the saturated fat. The omega-6s are actually essential components for us to make arachidonic acid, sex hormones, cholesterol. They are integral part of our mitochondria. We need them in the membrane. They actually make our own endogenous marijuana. That's how we get to avoid pain, but also be hungry. All right, this is how marijuana works. It stimulates our own endogenous opioids, and they are made from omega-6 linoleic acid. They actually tell our body winter is coming, you got to store fat. Okay, and they can become, if they are oxidized or high amounts, pro-inflammatory, pro-thrombotic. Omega-3s, okay, and especially the one that are at the end of the chain, 5 double bonds like EPA and DHA. DHA is for the brain, EPA is for the arteries. You need that DHA for synapses, for thinking. It helps us actually burn the saturated fat, opposite to omega-6s. And they are anti-inflammatory and vasodilator. So all of these are good fats, except when we heat them up. Once you heat them up, this is what happens when you start frying with it. These are 12 different vegetable oils. Notice we have 4 of them here. They have lower oxidation. Those are olive oils, the best olive oil, extra virgin olive oil you can imagine. But once you heat that up, it's half as bad, but it's still bad. Why? Because the oxidation depends on the concentration of omega-6s in those fats. And even the avocado oil and extra virgin olive oil still has about 15% of that. And that's what creates these compounds that we call alkanols. They are actually aldehydes and trans fats. And that is the problem. Okay? So here, if you want to predict which vegetable oil is the best or anything to heat, it has nothing to do with their melting point, contrary to what's been told to us. It has something to do with what kind of fat is oxidable when you heat it up or not, that creates those aldehydes. And if I were to look at that, sunflower oils, by the way, Romanians are big in sunflower oil. It's the best oil you can use, amazing taste, 60%, disaster. And you go all the way down to olive oil, 15%, avocado oil, about 14%. And then palm oils, and then see I put in green from omega-6, oxidation part, since like the tallow, coconut oil, and again butter actually are the less oxidizable, okay, from that perspective. All right, well, why am I so interested in that? Because if you heat anything with any kind of oil or fat, whatever omega-6 and 3s they have in it, under the heat, they become either trans fats, or the trans fats further they move to aldehydes. What's wrong with the trans fats? Number one is they stay forever in our body. We have no enzyme to metabolize that. They go into your lipid membranes in all our cells. They never go away. Number two, they're highly oxidizable, and basically they oxidize your cell, and they do part of that, what I was telling you about. Actually, there are experiments when done. You take a burger that's cooked with trans fats, and you leave it outside for a year. Not even bacteria can metabolize that. It's just as good as first day. All right, the same with the French fries. So that's important to know. And you say, well, you eat it, but it doesn't get absorbed from a gut. Not true. This is evidence showing you that they get absorbed. And the more oxidized your environment, the worse your hemoglobin A1C, the longer they persist in our chylomicrons and in our body. So they do get inside our body. And the damage that creates depends what your hemoglobin A1C and overall your oxidative status. All right. So the dietary actually oxidized fatty acids are so proportional to the level of the hemoglobin A1C in patients with diabetes. What is the ultimate worst bad fat is trans fats. And you say, well, trans fats have been banned about 10 years ago. You're not supposed to have more than 1% in anything you sell. Well, there is a catch. You still have this Crisco all vegetable shortening. You know what this used for? For the cheese in the Philly burgers or the Philly steaks, which is the best tasting, sandwich you have. And the reason is it's present new. You can find it at Kroger. And it's true. They don't have trans fats. Okay. This mac and cheese, all the prepackaged mac and cheese that you buy, that's what's used, vegetable cheese. And here is the key. Why? They're correct from chemical perspective. These are not trans fats. But the key word is fully hydrogenated or partially hydrogenated. All you need is one heating up and they convert to trans fats. So that's why it's legal. They can sell still this on the market. By the way, this is the same thing that Crisco came out with it over 60, 70 years ago. Nothing has changed. And of course, you're not going to eat it like that. You're going to have to melt that cheese. I'm going to use it. So I just want to warn you, just pay attention to anything that has partial hydrogenated or hydrogenated, you're eating trans fats. Okay? That's what I mean by processing. So it's disaster. And the reason why it's a disaster, because changing this from this as a straight chain, it creates aldehydes. Once they incorporate in our cell membrane, it's like have a source of fire that keeps refueling everything and keeps oxidizing nonstop our cells. And you say, well, it's okay. I don't buy that. I don't need that. Yeah. Well, do you buy this from cook cakes that are already made for birthdays? Do you bring it to your colleagues for their happy birthday? These are all trans fats. They're made the same. They're not made. Now, they're made with butter. That's why you make it home. Different story. But these are not made with butter. You know why? It costs 5 times more. They don't use that. So that's not right. Now you can look at this and say, hey, instead of using the shortening, I'm going to use the butter. I make myself at home. That's better. But you may be exposed more than you think. So how about this? You go, and when I'm going to eat healthy today, I always like to, I tell my patients to watch how our nutritionists eat when they go to cafeteria. You guys are an amazing role model, by the way. You know, you actually do what you say. And it's wonderful. It's a big salad, excellent. You know, put your chicken or your tuna fish there, eat very healthy. One catch, you add this little extra dressing that was just there ready to grab, and it's fine. Okay, let me help you to show you what do we have in that dressing. Total fat, 29 grams. Saturated fat, which is supposed to be bad for you, 5 grams. The toxic compound is what not in the label. It's because it's 29 minus 5, we have 24 grams of polyunsaturated fats. Now, where is that coming from? And if I were to divide 24 by 4, because 1 teaspoon is 4, I have 6 teaspoons of vegetable oil. You know, it's easy. You look at it, it says soybean oil. Now, soybean oil has already what we talk about, oxidized omega-6s that you put there. And then you have 100 other compounds, nobody knows their name. And I call them FEPs, flavor enhancers, emulsifiers, preservatives, and sweeteners, which now, little by little, everybody agrees they're bad for you. All right? But that's the problem. Once we do this, even if it's a very small amount, everything you ate that day is completely converted. Your liver and your body got the signal. Winter is coming. You're going to have to store this. Doesn't matter that you just ate a beautiful salad. So that's how we identify. Now, can you have a similar dressing? Yeah, get your own extra virgin olive oil, get your vinegar or lime, lemon that you like, squeeze it there, add some salt, get your dressing. No problem. It can be avoided. I'm just saying we don't know. Now, if I were to look in fried food, I showed you this last time. If you were to just bake or grill your chicken or bake your potatoes or bake your fish, beautiful, almost no fat there. Look, I listed there. At most a gram in 100 grams, very low, mostly saturated. But if I fry this, all that oil gets incorporated. You go to 14 grams from 0.4, 20 grams. Basically, all this goes up 50 to 100-fold, but not saturated fat. Is this oxidized, omega-6 fat? And I don't even talk about commercial fast food chains, but it's not that. The most concentrate is actually in the chips, in the potato chips, which is 10 times more than that. So few chips, they just did the worst damage you can imagine. But the problem is other compounds, we call acrylamide and aldehydes that accumulate. They're not even accounted for. And what's my problem with aldehydes? Here's my problem with aldehydes. We know now the mechanism of lung cancer, how smoking causes lung cancer. Here's how it causes aldehydes from, the fumes from the omega-6s, they're oxidized into that. They actually cause DNA damage and they cause eventually cancer because they inhibit our own, P53s that are supposed to inactivate cancer cells and prevent that. And there is a biochemist in England who actually, Dr. Goodfeldt, who look into and measure in French fries how many of those compounds that are incriminating cause lung cancer are present if you just have a small portion of French fries. And that's equivalent like you smoke a pack of cigarettes. So when you just had a small portion of French fry, you just had a pack of cigarette equivalent smoking cigarettes. The same compounds. They're straight into our bloodstream and gut. And if we actually look the common denominator, all these chemicals that I say they come from ultra-processed food, whether it's fructose, whether it's alcohol, whether it's smoking, and whether it's heated up vegetable oils or shortenings, they all work at the end through the same compound, aldehydes. And aldehydes are self-amplifying free radicals that changes mitochondrial function and everything else inside the cells. Okay, so that's the common denominator. That's why I want to put up. We don't need to memorize anything else. We just need to know they're different from the compounds that we've been feeding ourselves for prior 150 years. Basically, eat whole foods and cook at home. All right, and know what the danger comes from. And we have now plenty of meta-analysis. These are 3 different meta-analyses. Dose dependent, the more fried food you eat in a week, the more likely you're going to be sick and develop heart failure, cardiovascular disease, cancers, you name it. Okay, so that makes a difference. And yes, we have increased not only our sugar consumption, but also our vegetable oil consumption. We used to have 0 prior to 1900, okay? 0 vegetable oil. When Crisco introduced in 1902 cottonseed oil. And now we have 80 grams a day. Okay, and you can contest and you can say, oh, I don't know where you get that data. Well, it's not 80, it's 40. The lowest possible number is at least 40, which we never had it before. That means at least 10 teaspoons of vegetable oil. And why is that important? Because yes, they're essential. We need at least 2% diet every day, so we're healthy. But there's a difference between that and the oxidized, the heated version. Number one. Number two, we actually have increased that. We have increased that. And currently the ratio between used to be less than 4:1 or 1:1 150 years ago. Now the ratio between 6 and 3 is 20:1 for 6. AHA recommends 5 to 10% calorie a day. We actually at 24% currently. We have done exactly what they asked us to do for the last 50 years. Exactly. And it's not getting any better. One small fact, if I ate a nut today, half of the linoleic acid that was in that nut is still in my fat 2 years later. That's the body is designed to hold on to things that are essential, as opposed to saturated fat, which is much higher time turnover. So it's a big deal. Actually, our linoleic acid content in fat used to be 7%, now it's 20%. So we've been pumping up those compounds in us. The average American consumes 5 to 10 tablespoons of vegetable oil a day. If I were to hit my 2% minimum, it will be 1 walnut a day. That's different from that. Why? Because if I want to if I were to eat those omega-6s for those 5 to 10 spoons and they were not processed, I'll have to eat 100 years of corn. Okay, we don't realize how much we eat when we have just a little one of those pre-made packages. All right, so the dose makes the poison, like Paracelsus said, but also how we process them and heat them up makes a big difference. Okay, and I'm gonna skip that because we're getting late, but I want to show you that omega-3, one of the mechanisms how they work, they are antioxidant. This has been done in a lab by Dr. Preston here. You expose the LDL to hypoglycemia, it gets oxidized, you give back EPA, it prevents the oxidation, and it's supposed to prevent this change of local oxidation in the cells. The other agents don't do that. The way I would take this is think this way, that omega-6s are the fuel. Hypoglycemia is the arsonist that starts the fire, oxidizing, while the omega-3s are the firefighters. That's pretty much in a nutshell. And we have evidence now that supplementation of this EPA, not only they improves insulin resistance by markers, inflammation, but also oxidation and markers of fatty liver. So clearly something, and you just need 1% in your diet to do the job. And that's designed because omega-6s are the signal, evolution conserved signal to tell us our body, winter is coming, we need to store. That's why bears and squirrels start to eat nuts as soon as fall comes. The same how they eat fruits because it has fructose. These are the two elements that do that. And we know that actually, if you look at and you give saturated fat to a mouse, this is 35% saturated fat, this is 60% saturated fat. And all we do, we vary the linoleic acid from 1%, 8%, or we add back 1% omega-3s. And look at the mouse, 35% saturated fat, they get obese when they are on 8%. You give them 1% of good fat, omega-3s, change the ratio, they get better. 60% saturated fat, nothing happens until you give them the 8% of linoleic acid. Suddenly they get fat. You give them omega-3s, fix that ratio between omega-6 and 3, that stops it. Take-home message is not the saturated fat, even at 60%, that makes us fat. It's what's happening with the omega-6 to 3 ratio that tells us, our body, whether we're gonna store it or we're gonna burn it. Okay, saturated fat is neutral. It just does what it's been told to do. Either it's burned or it's stored. So that's important. All right. And then you say, wouldn't it be nice if I have a prospective randomized study to show me so rescue that, if I block this linoleic acid in my body, makes a difference. So I lose weight and I get better. And the answer is yes, we actually have the study. It's called the Rio North America study. We have a cannabinoid receptor called blocker called rimonabant. Rimonabant was Ozempic before it was Ozempic. In 2006, they developed this cannabinoid receptor. Basically, block the marijuana receptors in the brain, and those receptors are stimulated by products that come from linoleic acid. Our own endogenous opioids are used as a backbone linoleic acid, omega-6. And that binds to the receptor. Now we block those receptors. We lose actually 10% of the body weight, and we reverse metabolic syndrome. So cardiologists in 2006 were very happy about this. Finally, we found our way of how interfere with metabolic syndrome, also lose weight, and we can prevent cardiovascular disease. Catch, 3 years later, they had to take it off the market. Why? Because the same opioid. What? That's right. The same receptor we need, the same opioids that we need so we are hungry and we go foraging and eat, are the same one for pleasure reward system. So people have depression, they start to have suicidal ideation. Okay? We always know if you eat, you're relaxed, you're happy, but also you're in less pain. So they had to talk. So we have the mechanism. This is all omega-6 dependent. We've been proving it. Prospective randomized study, nobody talks about this. All right? Liver. Patients humans want to go liver transplant. We do the biopsies. The single most important predictor of how bad is the liver cirrhosis, how advanced, is the presence of oxidized linoleic acid in their liver. Okay, and the same with coronary disease. So what if I tell you, okay, well, cardiovascular disease, show me that we can do a prospective randomized study where we randomize them either to 10% vegetable oils, linoleic acid versus saturated fat. Do we have those studies? And the answer is actually we have them. They've been done 40 years ago when Ansel Keys came up with the hypothesis that saturated fat is bad for you and you need to lower your cholesterol. The results were, and they were done over a 7 years period, one in Australia, one here. Okay, the data was never published for 40 years until an NIH researcher, Dr. Ramsden at NIH, found the data and then published the study. So let's see the results. Yeah, is it true that if you eat vegetable oil and you cut saturated fat from animals, lowers your total cholesterol and your LDL? Absolutely. Is it also possible that, unfortunately, because those omega-6, if it's high amounts, they get oxidized, they can oxidize your LDL and theoretically cause more coronary disease and more cancers? That's possible too. Well, let's test it. Here's the results. Minnesota coronary experiment, over 7,000 people in nursing homes. They had controlled diet with saturated fat plus a little extra linoleic acid. Intervention corn oil diet, 13% corn oil, and they cut their saturated fat to less than 10%. They followed them for over 7 years. This is the total results. Overall, if you include all comers or age for over 45, no major difference. If you look in somebody who was older than 65, they start to have much worse mortality in the vegetable oil part. As a matter of fact, it is true the vegetable oil did drop the total cholesterol and the LDL, but for every 30 milligrams drop, there was a 22% higher chance of mortality, okay? And particularly if you're older than 65. And you can see here, all comers, that the lower was their cholesterol at the end of the study, the worse was their mortality if they're on corn oil. This is the secondary prevention study. This is the Australian study, Sidney, 450 men, was done in exactly the same time. All right, 450 men, prior heart attack, half randomized to regular saturated fat, however, fat coming from meats and butter, and the other one were randomized to 15% of energy from safflower oil. And then they followed them for the next, 3-4 years. Notice tremendous increased risk of total mortality by 62%, cardiovascular mortality by 72%, and coronary heart disease was a negative outcome data. It was never published until a few years ago, in 2016. Actually, Dr. Ramsden, put this together, found the tapes from both these studies. He was able actually to interview one of the original authors from Minnesota coronary experiment, and says, well, how come you, before he passed, or how come you haven't published this? I said, well, overall, we're just disappointed. Okay. So, by the way, this is published now in British Medical Journal. There's nothing, not even one word mentioned in the AHA guidelines or in any guidelines whatsoever. Okay. And as a matter of fact, our updated AHA guidelines insist that the best way to get your fats in the diet is from liquid plant oils, soybean oil, and canola oil. And I think that's a major problem. Now, they made some progress trying to reduce. They recommend to reduce the ultra-processed food, cut the sugar to no more than 16 spoons a day if you're a woman, 9 teaspoons if you're a man. So there is some progress. Recommend Mediterranean diet, which is, by the way, a high-fat diet. It's not a low-fat diet. All right. But they still have this there. Okay. Basically, in a nutshell, the guidelines have not changed since 1977, at least if you were to order a cardiovascular diet in any hospital in this country. All right. The good news is, to me, we should put all the vegetables on this side, according to a totality of evidence-based medicine, not just the ones that we like to pick and choose. And the good news is, American Colleges of Cardiology, this is a review paper was published in 2020. It was actually the highest cited paper in that year. And it said there is no evidence that saturated fat from animal food actually causes cardiovascular disease. That's not a problem. We need to look at the evidence. So at least we're not alone recommend this. And I can show you this. We started this about 15 years ago in the lab. I wanted to create a heart failure preserved ejection fraction model. Dr. Anania is the hepatologist is a really world expert in fatty liver. So he had this nice mouse model where you just put them, and when they're at puberty, about 5 weeks or 8 weeks after they're born, on this combination. And I didn't know back then. I literally put them on the chemicals that I think they're bad for you in the diet, in ultra-processed food. 30% partially hydrogenated vegetable oil, 13% soybean oil, just like in Minnesota Coronary experiment, and 2% fructose, which is equivalent of a soda day of fructose. So we follow them, and yeah, model is very well characterized. They get obese, they get fatty liver, dyslipidemia, inflammation, insulin resistance, and my job, to my shock, they get cardiomyopathy. I thought I'm developing a heart failure with preserved ejection fraction model. Turns out eventually starts with that. Eventually they develop dilated cardiomyopathy, just like you have coronary disease. No high blood pressure, by the way. It's pure straight the metabolic effect. And here, as you see, this is oxidase stress measurement, because that's what our lab was expert in. Oxidized DNA after 4 weeks of diet in the heart, oxidized lipid membranes. By the way, this is exactly what I was telling you, 4-HNE, hydrononanol. That's oxidized linoleic acid in omega-6 in the lipid membranes of the cardiac myocyte, in everything, including the mitochondria. So yeah, it gets oxidized. And yes, we get insulin resistance. That means the glucose is not, the insulin pathway is not used to absorb and use the glucose to burn in Krebs cycle. It's used as a growth factor. Okay, all right. And then high, insulin. Then this is the evidence with when we did echoes on these mice, and they get after 8 weeks, 12 weeks, they start to develop cardiomyopathy. And then when we look at the RNA analysis, we see that those cardiac myocytes decided to shut down mitochondrial function to make ATP. They have insulin resistance equivalent fetal phenotype and a metabolic inflammatory oxidase stress mitochondrial phenotype. So then when we look at the RNA, we saw the angiotensin converting enzyme was like 10-fold elevated as early as 3 weeks. So I said, well, let me give them an ACE inhibitor, see what happens. All right. In other words, as soon as you put them on this diet, in the heart, your angiotensin production goes up. So we gave them captopril. Guess what? Not only we reverse obesity, visceral fat was completely blocked. Again, you do this at the beginning. We didn't wait for them to get sick. We prevented it, so to speak. And then now that's not going to happen with humans. The moment they start ultra process, we're just going to give them their captopril. It just makes no sense. But it proves the mechanism that Ang2 is very early involved, and a very strong connection with nutritional compounds here. So the glucose tolerance reverses, but also the cardiomyopathy. Okay, so we know this is angiotensin II dependent. Somehow it does that. Then Dr. Anania was the first to actually show that if you use a GLP-1 receptor agonist, which was basically before Ozempic, we had liraglutide, it reverses fatty liver in these mice. And guess what? When you reverses fatty liver in these mice on the same allulose diet, it reverses their insulin resistance, but also the cardiomyopathy. So what this tells you, heart is an innocent bystander that's impacted by the insulin resistance, but the disease starts in the liver, just like with the cholesterol and coronary disease. You fix the liver problem, you fix everything else. Okay, so then I thought, okay, cool. So why don't I see if I can, inspired by the Lions trial, which is the most impactful dietary study we had in patients with coronary disease. They showed people this was done in France many years ago. A lot of people have forgotten. In 94, published in Lancet. They put them on Mediterranean diet, but really and you show after 4 years, 72% reduction in cardiovascular mortality. Obvious all-cause mortality by 44%. This has never been achieved in any clinical trials for cardiovascular prevention. Now, that was before statins, so we don't know what that means from that perspective. Nonetheless, what they really had this in common was the fact that their omega-6 to omega-3 ratio improved from 19 to 4.4. That was the single most important defining factor other than cutting ultra-processed meats. All right, so we suggested, what if you reverse this ratio? That may make a difference. So I said, I'm going to go back to my mice. I'm going to add back some omega-3s, which is equivalent of either 2,000 milligrams of omega-3s for us, fish oil, or 4,000. I did actually a dose response. So I put them back on the same diet. We repeat this is the third time. Third time is the charm. And without the omega-3 supplements, the ratio between 6 and 3 is 2 to 1 is this diet. Then I added the equivalent of 2,000 milligrams for a human is 6.5. That would be 0.75%. Remember, this is 30% that way. And then I added 1.5% would be, which reverse that ratio 3.1. We look first at the liver, I said, and then, big improvement. And this is what you see in red is the fat in the liver. Okay. Then we look at the insulin resistant, big improvement, dose dependent, fatty liver, very dramatic the impact from 40% of livers being loaded with fat to down to 10%. Not perfect, but tremendous. In the same way, heart cardiomyopathy has improved. Didn't completely reverse. It wasn't the only thing. I don't know, was the dose was too low? It doesn't matter, but it shows you in dose dependent. That's the direction. And then others are looking to a high cholesterol model, LDL cell receptor knockout, look at aortic atherosclerosis, changing this ratio again, big prevention of atherosclerosis, even if you have a genetic background where you don't have an LDL receptor. So bottom line is I'm trying to propose to you is when we eat something, what gives us the taste, which is the sweet fat that we heat it up, okay? All right, which is the brown sugar and, it's heating up fructose and glucose attacks the polyunsaturated fatty acid omega-6. Together, they oxidize the protein. That gives tremendous taste. It's the umami taste that we all enjoy. But at the same time, this is absorbed in high amounts in a highly oxidized environment, like somebody's prone for diabetes metabolic syndrome, that's actually bad for us, okay? And these are the biggest culprits possible because it's 10 times more concentrated. I have no problem making that turkey. That's a turkey I make. I add plenty of brown sugar when I do it, but this happens once or twice a year. This is not an everyday that you just ate something at lunch and you grab your potato chips bag that you're doing. So I'd like to point out, if you think all I'm talking about, inflammation, oxidative stress, hey, I got a lab value for you that tells you where you are. Go and check it for yourself, by the way. And you want to be as close as possible to 5. And you do serial measurements from 1 year to another. If that starts to go up, you're moving in the wrong direction here. And you can do better. Hemoglobin A1C is not the only one, because then it tells you we're getting older, we get impaired mitochondria, and we do this. And there are some other things that tells us. Okay, remember, it's not a total LDL matter, it's the oxidized part that matters. And the oxidized part that matters is because what's oxidized? Well, we have an ApoB, which is the receptor for the oxidized. Well, that ApoB is oxidized by glucose, like I told you, is the arsonist. Glucose, fructose, 7-fold worse than glucose, and methyl glyoxide, which is a byproduct of fructose, 250-fold. And that releases hydrogen peroxide, attacks the ApoB. And guess what? Once ApoB is oxidized, it's no longer recognized by the liver. So if it's not recognized, it just hangs around and eventually gets deposited somewhere and gets more and more. Okay? And yes, statins are not going to impact this because you can upregulate all you want your LDL receptor in the liver. If you cannot recognize an oxidized ApoB, it doesn't matter. That's why it doesn't work. All right? And then the other part that's oxidizing the LDL is the fatty acid triglycerides that are connected to cholesterol. 95% are linoleic acid, and those come only in the diet. Remember, body does not make it. So that's the problem. They're oxidized, and together cause the damage. So it's not the total LDL that matter, but the oxidized part. And these are other lab values that you can use surrogate. Hemoglobin A1C is not the only one. I just moved that up. Triglyceride HDL ratio more than 2.5, uric acid more than 5, that's another one, homocysteine more than 12. We go to SoRescue, to the rescue, SoRescue heart failure lectures. It's all there. But bottom line is, I advise them fast, but I don't mean fast 24 hours. I'm talking about every hour or at night. The longer you have the period between your meals, the better. Very simple. There is never in human biology ever a time where we actually have snacks. It's a food industry invention. There's zero reason to ever snack between your main meals. Okay, it's toxic. Second, because your insulin goes up. So you keep doing this yo-yo with the insulin and everything else is a problem. Cut the sugar and refined carbs because those are the most potent stimulators for insulin. You want to keep that down. It's not the only thing. Cut the vegetable oils because remember vegetable oils, omega-6, too much. It tells your body what to do that day. Doesn't matter how much you exercise. You're going to store or you're going to burn. But you're not going to burn if you had too much vegetable oils in that day, particularly if they're oxidized. Eat marine fish. Remember, omega-3s do the opposite. I like the real deal. We have evidence it's not oxidized, not farmed, very little omega-3s. You don't want to eat the big fish, they eat other fish. Tuna. I mean, you can eat that maybe once a week, no more than that. If you're pregnant, definitely no tuna or eat fish. They eat other fish. Eat the small fish, sardines, salmon. Those are the kind of things that makes the difference, and they have at least usually for a small can sardines 20 grams already proteins, and you get also about 2,000 milligrams of real omega-3s. Exercise 30 minutes daily. Why? Exercise never helps you lose weight, but keeps you metabolically healthy. Remember, muscle is the biggest user of glucose and fats. So it goes there, but also it stores your proteins. We don't lose weight when we exercise. What happens is it turns on the metabolic. After the muscle have emptied everything they had, they need to recharge and get all that back, both the glucose and glycogen there. So what happens 12 hours after the exercise, that it drags it back into the muscle. That is what is healthy for us from metabolic perspective. All right. And this is what I say. Have a breakfast that's heavily loaded with proteins. Could be eggs. Get your veggies in every form. You can have some cottage cheese, again, non-processed cheese, avocados, for lunch, any form of fish with some kind of vegetables. I like the sardines. Why? You don't have time to cook. You just open them up, get rid of the oil, squeeze a lemon. It tastes just like chicken, and it's tremendous. And it fills you up. You're not going to snack again. I promise you. You feel full. That's how Mother Nature created for us. And then, yeah, they work. Careful with the supplements, because many supplements are already oxidized. So I don't like, unless you have a lab that those supplements are good quality, they're oxidized. So it's like, might as well just fry my fish. It's the same thing, unless you know a clean source, which I don't know. So I tell you, just eat 3 times a week some kind of fish that's marine. All right. Okay. Now, those who, let's say, I just told you omega-3s are important, believe it or not, and this is not evidence-based medicine, you don't have to do it, but you can check your own omega-3 level actually in the plasma membrane. And why? Because we know if its index is more than 8, 0 incidence of heart attack or cardiac arrest. Not absolute, but it's another way of looking at it. And if you guys need to go, there's a code going on. All right. So, and you can actually buy this kit from Amazon. I don't advertise or anything. I did it for myself. And it shows you what your level is. You could be at 8. You just go up on your fish, and then you can check it again, and it gets better after 3 months. Big difference. Then you know if you're at least approximately you're eating. It motivates. I have patients who are vegetarians. They say, I'm taking my supplement. I showed them that bigger vegetarian supplements don't work for omega-3s. And then ate 3 times a week salmon, then it made the difference. So those are something you may want to consider for those who are motivated. But at the end of the day, I think I'm going to stop here because I went over time a lot. But for those who are interested, you can just go to Rescue Heart Failure lectures, and you can see most of these lectures in lots more details. And anyway, I hope this was useful. Right.